Let's jump right in. Welcome to The Explainer. Today, we're unpacking a literal game changer in respiratory care, the 2026 Global Initiative for Chronic Obstructive Lung Disease, or GOLD report. Look, this isn't just your standard tweak to a couple of treatment tables. We are talking about a massive, fundamental paradigm shift in how we assess and manage COPD. The biggest takeaway: we are officially entering an era with a strict, zero-tolerance policy for exacerbations. As we walk through this, you're going to see exactly how the new clinical guidelines push us to catch the disease way earlier, treat it much more aggressively, and honestly completely redefine what it means to actually control COPD. Okay, let's dive into our roadmap for today. We're going to cover the growing global burden, smarter screening, the updated ABE assessment, new vaccine recommendations, the crucial split between initial and follow-up treatment, and finally, rethinking exacerbations. Kicking things off with Section 1, the growing burden, and why this is a true global health crisis. To really grasp why the 2026 guidelines are coming in so aggressively, we first have to look at the sheer scale of what we're up against: 600 million. Based on the latest modeling data highlighted in the report, the number of global COPD cases in people 25 and older is projected to jump 23% from 2020 to 2050. That puts us right around 600 million patients. And the demographics are shifting too. The fastest growth is actually happening among women and in low to middle income regions. We really need to drop the old stereotype that this is just a disease of elderly male smokers in high-income countries. It is a rapidly escalating, universal health crisis. But here's the stat that really serves as the why behind the new guidelines. Up to 70% of adults with COPD around the world remain completely undiagnosed. Just think about that. The vast majority of our patients are out there suffering in silence, totally untreated, while their lung function steadily declines. The report calls out a mix of patient, provider, and healthcare system factors for this gap. I know it's incredibly frustrating in clinical practice, but the harsh reality is we literally can't treat what we don't find. Which leads us perfectly into Section 2, smarter screening and case finding. To tackle this massive underdiagnosis issue, the 2026 report lays out some highly pragmatic case-finding strategies. This new algorithm is brilliant because it targets at-risk individuals, specifically anyone 35 and older with risk factors like tobacco use, biomass exposure, or lingering respiratory symptoms. But instead of jumping straight into complex diagnostics, it suggests a simple pre-test using validated screening questionnaires like CAPTCHA or the CDQ. If they flag positive, the pathway splits into two very practical routes. In primary care, clinicians can use super simple handheld tools like a peak flow meter or a COPD-6 microspirometer. If those show obstruction, or if you're already in specialty care, then you move to the formal pre- and post-bronchodilator spirometry. It's a much smarter, systematic net to catch that missing 70%. All right, moving on to Section 3, the new ABE assessment. Now, we are getting to what is arguably the biggest paradigm shift in the entire report when it comes to assessing patient risk. Look at the clinical delta here. In the past, you generally needed 2 moderate exacerbations or one that landed a patient in the hospital to bump them up into the high-risk category. Well, the 2026 paradigm completely shatters that. Now, a single moderate exacerbation puts a patient directly into the high-risk group E. Why the sudden change? Because emerging observational data is crystal clear. Even one moderate exacerbation before starting maintenance therapy heavily spikes the risk of subsequent worse events. This is that zero-tolerance approach in action. Now, what's really interesting about this slide is how the updated ABE assessment tool visually locks in this zero-tolerance policy. Check out the exacerbation history row on the left. It explicitly says 1 or more moderate or severe exacerbations in the previous year. The second your patient hits that threshold of just 1 moderate event, boom, they are pulled out of groups A and B and pushed straight up into group E. The threshold for escalating care is lower than ever, and it's all about protecting our patients sooner. To match this aggressive new risk assessment, the report introduces a brand new formal clinical target for us: low disease activity. It defines this as a clinical state with absolutely no exacerbations, no worsening of symptoms, and no accelerated loss of lung function. This is our new North Star, folks. We're no longer just aiming to make patients feel a little better day to day. We are actively trying to freeze the progression of the disease to achieve this exact state. Let's transition to Section 4, updated vaccination recommendations. If we want to achieve that low disease activity state, our absolute first line of defense isn't actually an inhaler. It's proactive, preventative vaccines. Alongside the standard yearly flu and updated COVID-19 shots, there are 2 major updates you need to know about. First, the pneumococcal recommendation has been modernized. We're now looking at either a single dose of the 21-valent PCV21 or the 20-valent PCV20 to curb community-acquired pneumonia. Second, and this is huge, RSV vaccination is now strongly recommended for folks 15 older with chronic lung disease. You can use either the pre-fusion F protein or mRNA-based vaccines. Stopping these viral triggers before they start is absolutely paramount to maintaining that low disease activity.
Moving into Section 5, initial versus follow-up treatment algorithms.
Let's get into the climax of our clinical journey today, the pharmacological treatment algorithms. For 2026, the report does something incredibly helpful. It explicitly separates the management cycle. The very first question you have to ask yourself now is my patient therapy naive? If the answer is yes, you go straight to the initial treatment algorithm. If no, meaning they're already on some form of maintenance pharmacotherapy, you head down a completely separate review and adjust pathway. This brilliantly clears up the old confusion of trying to use initial diagnostic groupings to manage a patient who's already been using an inhaler for 3 years. Let's move to these algorithms and see how this builds. On the left, you've got initial treatment for therapy-naive patients, which is based entirely on that ABE grouping we just talked about. But look at the follow-up treatment algorithm on the right. Notice anything missing? It doesn't care about A, B, or E anymore. Instead, it zeroes in on 2 specific treatable traits, persistent dyspnea and the occurrence of exacerbations. You evaluate their current symptoms, double-check their inhaler technique and adherence, always crucial, and then slide down the appropriate pathway on the right to escalate or switch up their molecules. So, what does this actually mean for your prescribing habits? The bottom line is this. For initial treatment, both Group B and the high-risk Group E should be starting on a LABA plus LAMA combination. Dual bronchodilation is the standard here. Now, if they're in Group E and happen to have a blood eosinophil count of 300 or higher, that's your cue to consider adding an inhaled corticosteroid for initial triple therapy. During follow-up, if they're still exacerbating despite the LABA-LAMA combo and those eosinophils are elevated, you escalate to triple therapy. And get this, the 2026 report now clearly maps out the use of targeted biologic therapies like dupilumab or mepolizumab for those rare tough cases where patients are still exacerbating on triple therapy with high eosinophils. It's a real game changer. Finally, Section 6, rethinking COPD exacerbations. What happens if our preventative vaccines and maintenance inhalers fail? Well, the 2026 report has completely revamped how we objectively classify exacerbation severity. Historically, we just graded severity based on healthcare resource utilization. Did they get antibiotics, oral steroids, or a hospital bed? But honestly, that is incredibly subjective. So now, GOLD has officially adopted the Rome proposal. This grades severity as mild, moderate, or severe using hard objective clinical parameters. The visual analog scale for dyspnea, respiratory rate, heart rate, oxygen saturation, and CRP levels. For example, a severe exacerbation is now specifically differentiated by the presence of hypercapnia and acidosis, so a PaCO2 greater than 45 and a pH less than 7.35. This finally gives us a universal, objective language right at the point of care. And this brilliantly illustrates that when an exacerbation is over, the care absolutely does not stop. The new guidelines lay out rigorous discharge criteria and follow-up timelines. We are now explicitly mandated to do an early follow-up between 1 to 4 weeks and a late follow-up between 12 to 16 weeks post-discharge. And these aren't just quick check-ins to say hello. We need to actively reassess their maintenance therapy, audit their inhaler technique, figure out if they need long-term oxygen, and make sure they understand exactly how to safely taper off their acute meds. This structured, proactive follow-up is proven to keep patients from bouncing right back into the hospital. So we've covered this staggering global burden, those much smarter screening algorithms, the Rome proposal, and of course, that massive shift in the ABE assessment. And while the full report also dives into multimorbidity and even how AI is emerging in COPD management, everything really circles back to this zero-tolerance mindset. With just one moderate exacerbation now serving as the definitive trigger for escalated therapy, the question I want to leave you with is this. How quickly can your clinical practice adapt to this new standard? The roadmap is right here in front of us, but it's up to us to actually put it into practice. Thanks so much for joining me on this explainer, and keep learning.